Hey, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. We are continuing on with our cardiovascular topics, and I am going to tackle nitrates in general, how they work, what they're used for, all that good stuff. But before I do that, be sure you go to reallifepharmacology.com, take advantage of the free 31-page PDF. It's a study guide of the top 200 drugs, tons of no-brainers, things that are going to show up on pharmacology exams and board exams, as well as stuff that just happens in real life as well. So again, go take advantage of that at reallifepharmacology.com. Simply an email will get you access to that. All right, so let's get into nitrates. So stepping back from a big picture aspect, nitrates are vasodilators, and the use that I've seen most in practice is management, prevention, treatment of angina and acute coronary syndromes, and they benefit the heart specifically by reducing myocardial oxygen demand, and they can also increase coronary blood flow to the heart as well. The clinical uses, a couple examples I alluded to already: angina, acute coronary syndromes. These medications do drop blood pressure as well, so you may see them in hypertensive emergencies with ischemia and poor blood flow. Occasionally you may see utilized for heart failure under certain circumstances. And then topically, I want to mention nitroglycerin ointment, for example, can be used for anal fissures. All right, how does this medication work? What's the mechanism of action for nitrates? So all nitrates are converted to nitric oxide. That's often abbreviated as NO. And in vascular smooth muscle, nitric oxide activates guanylate cyclase, and this increases cyclic GMP. Okay, that increase in cyclic GMP ultimately leads to smooth muscle relaxation. So we get this dilation of the vessels, particularly veins or venous dilation. That's mostly what happens, and that decreases preload and also decreases myocardial oxygen demand. I do want to add, while that venous dilation is predominant, as we escalate dosages, we may get more arterial dilation as well. So that's kind of a little side note there to pay attention to as doses escalate. In anal fissures, what this medication does, obviously it works the exact same way. And then it ultimately, by increasing again that cyclic GMP, it causes smooth muscle relaxation. This reduces the anal sphincter pressure, which is often higher in chronic anal fissures. It also helps improve blood flow to the area. So again, that relaxation of the sphincter increases local blood flow. And chronic fissures often fail to heal because of lack of blood flow or ischemia. So that improved blood flow or perfusion to that area helps promote the healing. May also help a little bit with spasms that are associated with anal fissures as well. Again, by relaxing that sphincter, that can help with reducing that pain and those spasms associated with defecation and going to the bathroom there. All right, so let's get into a little bit more specifics about individual agents. So nitroglycerin, specifically, this is the most commonly used agent I see. Probably the most common thing you'll see in practice is nitroglycerin sublingual tablets if you're on the ambulatory side. And then certainly nitroglycerin can be used as an IV infusion as well. It is available by a transdermal patch too. And I will note that when we give nitroglycerin orally, there's a tremendously high first pass effect. And so that's why it typically isn't utilized that way. We've got sublingual, we've got IV, we've got transdermal. These all really bypass that first pass effect. The sublingual, most common situation you're going to see that used for is acute chest pain. Onset is typically within a couple of minutes, usually in the range of 1 to 3 minutes, and then lasts in the neighborhood of 30 minutes. IV infusion, obviously that's going to work very quickly as well. As soon as we get that going, you're going to start to see benefits with that as well. Now, the transdermal patch, this has a delayed onset and a prolonged duration. Remember, that drug takes a while to get through the skin. So that's an important thing to pay attention to. So that patch is for prevention of recurrent angina. Okay, most oftentimes used in combination with a beta blocker is what I've seen in practice there as well. Another thing with the patch and with nitroglycerin in general and nitrates in general, we need a nitrate-free period to reduce the risk for tolerance of the medication. And so with the dosing of the topical patch, you're going to see transdermal use for a period of 12 hours on and 12 hours off, or at least that's the most common in practice. So that patient typically needs a 10 to 12 hour period where we aren't getting nitrates to reduce the risk of that tolerance developing. So that is definitely a highly testable pearl for sure. All right, let's talk adverse effects. So headache, very, very common with nitrates. Okay, so that's the number one, I would say, most common one, followed closely by hypotension. Naturally, we're dropping blood pressure. We're causing vasodilation potentially. That's going to drop blood pressure and obviously can drop it too far, cause some dizziness and those type of things. You may see some reflex tachycardia. So when that blood pressure drops, the heart may tend to pick up in pace and intensity, and that can raise pulse. So we'll want to monitor that as well. Flushing, kind of a redness in the face, that can happen with this medication as well. A few practice pearls to pay attention to. Obviously, when using sublingual nitroglycerin, we're going to drop that blood pressure. So making sure that patients understand that and that we probably shouldn't be moving around a ton and those type of things. Need to pay attention to blood pressure very closely. And then that tolerance I alluded to as well. Isosorbide dinitrate, another different dosage form that's still considered in the nitrate family, often abbreviated as ISDN, so that's something you might see there. This is most commonly used for chronic angina. That's what I see in practice anyway. Occasionally, maybe a down-the-line option for heart failure if patients have failed other medications. Oral bioavailability is okay, or it's better than nitroglycerin. We tend to avoid a little bit more first-pass metabolism with this dosage form, and that's why we can give it orally. It does have a shorter half-life than isosorbide mononitrate, which I'll talk about coming up here. This medication typically does require multiple daily dosing. So if you remember the dinitrate, di being 2, that's a good way to remember that that's going to typically require multiple dosages throughout the day. Isosorbide mononitrate, this is the medication I would say I would see most commonly for prevention and management of chronic angina symptoms or chronic angina prophylaxis, if you will. High oral bioavailability, so that's good. Generally avoids significantly that first pass metabolism. And it's got a longer half-life, so we can typically get by with once daily dosing with the extended release formulation. And that common brand name is Imdur. tolerance, again, that applies to all these dosage forms. So we need that nitrate-free period. Usually it's in the neighborhood of 10 to 14 hours. Again, removing that patch, that's important. And then that's why we don't, for an example like IMDR, where we typically just give it once daily, we're going to get that nitrate-free period if we only take it once daily. But if we were to take that twice daily, once in the morning and once in the evening or at night, that would basically wreck that nitrate-free period. So that's why that typically is not going to be done. All right. Contraindications and drug interactions. Before I get to that, I want to mention if you're in the market for any pharmacist board certification study materials, BCPS, ambulatory care, geriatrics, Naplex, go check out meded101.com/store. We've helped thousands of pharmacists pass their board exam and can absolutely help you too. So again, tons of resources, lots of different professions as well, books for nurses, books for dietitians who are studying medications, all sorts of great resources at meded101.com/store. All right, so those drug interactions. Want to cover the PDE5 inhibitors, sildenafil, tadalafil, vardenafil, definitely a contraindication to the use of nitrates, okay? And more specifically, sildenafil within 24 hours and tadalafil has a little longer half-life, so that avoiding that combination within 48 hours for tadalafil and nitrates. So the risk, what's the risk of using PDE5 inhibitors like sildenafil with nitrates? The risk is severe or life-threatening hypotension. So that blood pressure drop can absolutely be substantial for sure. Other drug interactions to pay attention to, any type of blood pressure lowering medication, calcium channel blockers, ACE inhibitors, ARBs, alpha blockers for BPH, for example. These can all add to the hypotensive effect. So we're going to be monitoring that blood pressure and potentially pulse as well if we're worried about the risk of reflex tachycardia and those type of things. And then alcohol can potentiate some of the blood pressure lowering effects. May see a worsening of flushing as well. I've seen that in practice, as well as dizziness and the increasing fall risk. So pay attention to that. And then other drugs that are considered vasodilators, hydralazine, minoxidil, these can cause some pretty profound orthostatic hypotension. Again, not used terribly often, but something to pay attention to. From a patient education standpoint, if we do have to use these combinations, or maybe we're just starting a nitrate and they're on a bunch of other blood pressure lowering medications, really pay attention to educating patients on getting up slowly with positional changes. So from lying to sitting, sitting to standing, and we start moving around, that orthostatic hypotension with those position changes can be pretty prominent in that patient population. All right, well, I think that's going to wrap up the podcast for today. Do me a huge favor if you enjoyed this episode. Leave me a rating review on iTunes or whatever platform you're listening on. If you want to track me down, Eric Christensen, PharmD, BCPS, BCGP on LinkedIn. Best is probably email, mededucation101@gmail.com. If you got comments, questions, suggestions, I'm definitely all ears for that. I do my best to respond to your emails within 2 or 3 days. If you haven't heard from me within that time frame, don't hesitate to reach out again. I do my best to try to get to all my emails. I get quite a few, but again, do my best to try to respond to everything. So with that said, support the sponsor, meded101.com/store. Appreciate all the support. Take care. Hope you have a great rest of your day.